It's the smaller LDL particles that appear to carry much of the risk.
So is it worth trying to increase the LDL size? I have a lot of particles and they're smaller. Should I try to make them larger?
No. That give you one word answer. The answer is no. Some people have interpreted the work that I've done to suggest that in the work I described, that large LDL are benign. That's not true.
Dr. Ron Krauss is a medical doctor, clinical lipidologist, and professor at UCSF and UC Berkeley. Over his career spanning many decades, he has published hundreds of research studies on heart disease and metabolism. Stay tuned for the recap at the end of the video. If you were to explain to someone who doesn't have a lot of scientific training, or let's say none, but is interested and wants to know maybe a couple of initial things about heart disease, what do we know about what causes heart disease, cardiovascular disease?
Cardiovascular disease, which of course is the major cause of death around the world these days, is mainly due to blockage of circulation to the heart by the buildup of plaque, which consists of cholesterol and other substances that can lead eventually to closing off the circulation, and that's what can lead to heart attacks, and as well as stroke when that occurs in the blood vessels that feed the brain. And so that's the way the process starts, and that's the way it hopefully doesn't finish. If we are able to intervene on that process, we can prevent those bad things from happening.
Yeah, on that note, what are some of the things that if you had 30 seconds with someone, again, someone who doesn't have a lot of in-depth knowledge, and they wanted to know, okay, what are some simple things that I can do, let's say to prevent, let's say they're still relatively young and they're trying to prevent heart disease?
Well, there are a number of factors that contribute to heart disease risk. Among them are things like high blood pressure, diabetes, and of course, cholesterol, which is one of the major factors that can promote formation of plaque and lead to heart attacks and stroke. And so these can all be controlled primarily initially by lifestyle. We know that excess body weight, particularly if you have fat around the middle, can lead to a whole host of disturbances, including those that I mentioned, as well as ultimately promoting the risk of diabetes itself. And so we emphasize for those individuals who have not established a healthy body weight and a healthy waist circumference, which is one of the ways we assess fat around the middle, that would be the first step in trying to reduce the risk of heart disease. Now, that often fails, unfortunately, in part because of genetic factors, things we can't control that are built into our wiring system. And in those cases, we can rely on medications, which are fortunately available for all of those things now, even including weight reduction. Certainly, cholesterol lowering is one of the main factors that we focus on, because that has proven benefits in reducing heart disease risk. And we can talk, perhaps, if you wish, about the medications and the way we use them. But that provides a very effective way of lowering heart disease to very low levels when diet and lifestyle fail. Now, of course, exercise is a part of that equation as well. It can improve all of the factors we talked about and can also help promote maintaining a healthy body weight. So these things together really point to lifestyle as a central component of risk reduction. But from a medical standpoint, we do have other tools that we can employ when lifestyle fails.
It's interesting that among all the factors that you mentioned, most of those aren't really controversial. If you tell someone, okay, tobacco, healthy body weight, blood pressure, very few people will argue with that. But once you name cholesterol, the whole internet breaks out into camps and different views. So it's kind of an interesting selective treatment of cholesterol as a unique risk factor. And I think to a large extent that's understandable because it is a more complicated field, and maybe it's not the cholesterol itself, it's the particles that transport cholesterol into the artery wall. So that gets complicated, admittedly, and the evidence is also all these nuances. And so, yeah, that's something that I was hoping that we could spend some time on is this question of the particles. I know you've done a lot of work on that, and so I'm trying to understand. I watched some of your interviews, and I heard you state your position a couple times, but I'm still not 100% clear on what your view currently is on the particle size question. Um, all particles, if you wish, but or specifically LDL, the small versus the large. What's currently your position on that, and with regards to risk?
Well, as you said, I've been deeply involved in this arena for many years, so I'll be happy to address your questions. But let me start off by just backing up on the issue of cholesterol itself. Cholesterol is a waxy substance that doesn't circulate in the blood all by itself. It is part of a complex, which is a particle, a spherical particle that contains not just cholesterol, but other fats, as well as a number of proteins. And that collection of material is what winds up entering the artery if there's excessive levels of it in the circulation. So we move from talking about cholesterol itself to lipoproteins, and specifically to a category called low density lipoproteins, or LDL, which transport most of the cholesterol in the blood. And they're the ones that we have abundant evidence wind up delivering that cholesterol into the artery and lead to the formation of plaque and ultimately can block the circulation. And it's been important both clinically as well as scientifically to understand that it's the particles that we really need to be evaluating and monitoring if we're going to get a true assessment of heart disease risk. The standard blood test that most individuals get as part of screening for heart disease these days is called LDL cholesterol, and that measures the cholesterol component of LDL particles, which in large measure correlate with the number of particles themselves, but it's not a perfect fit. That is, you can have either high or low LDL cholesterol levels and still have abnormal levels of LDL particles. And that's not yet widely appreciated. And it's in part because the testing for LDL particles has not become a widely utilized test. The tests are available in various forms, but they haven't really been widely employed in risk assessment. So we tend to fall back more often than not on LDL cholesterol, and we often miss abnormalities that involve high levels of LDL particles. So having established at least the causal role of LDL particles as the agents that deliver cholesterol into the artery wall, we now have to understand there are different categories of LDL particles in the blood. There's multiple what we call subfractions, and they vary in various properties, most notably size, so that there are larger LDL on the one hand and smaller LDL on the other. Now, interestingly, it's the smaller LDL particles that appear to carry much of the risk for buildup in the artery wall. Even though they don't transport as much cholesterol, actually the larger LDL happen to have more cholesterol in them. They're more fully packed with fats. But the smaller particles, despite their lower cholesterol content, have a number of other properties which we and others have studied, which are relevant to the question of what we should be thinking about when we try to reduce heart disease risk by lowering LDL. Those smaller particles can get into the artery wall more easily than a larger LDL. So what we see is a movement of LDL from the bloodstream into the tissue of the artery, and that can be enhanced with the smaller LDL particles because they have less obstruction on the way into the artery. Beyond that, there are effects which really create a toxic effect on the artery wall. Among them are a tendency for the smaller particles to stick more tightly to the artery, we can sometimes see LDL particles moving out of the artery as well as into the artery, but the smaller particles enter in more readily and get stuck more easily. And once that happens, a very important step occurs, and that is they can become oxidized. And we know that oxidation is a very important step that sets the stage for a very key aspect of heart disease beyond the cholesterol is inflammation. Once the LDL particles get oxidized, they set off an inflammatory set of events that amplify the damage in the artery wall and combine with the high cholesterol to form these nasty plaques. And so those smaller LDL particles are more susceptible to oxidation than larger LDL. So when they get oxidized more readily, they're sticking in the artery wall. That's where the damage really gets to be more significant. Now, those are those observations are really based on strong science. I mean, we know that the small LDL has those properties, and we would therefore expect that smaller LDL particles, elevations of them, would be a particular concern for heart disease risk. But that's where the agreement ends and the controversy begins, because one can accept all of those events, all those effects, but one can still argue, as many do, unfortunately, in my view, that it really doesn't matter whether the particles are large or small. And some people would even go so far, we can talk about this, as to claim that the LDL isn't relevant at all. There's even that element in the world that has disputed the role of LDL. We can talk about that a little bit more if you wish, but where I've taken this discussion is in the other direction. That is, LDL are involved in the formation of plaque and the development of coronary heart disease and stroke. But are the smaller LDL really something that we should be concerned about? And that moves us into the realm of clinical evidence. Do we have strong clinical evidence that levels of smaller LDL are more predictive of heart disease risk than either the larger LDL or the LDL cholesterol? And I've reviewed this extensively at some of our own work, certainly, but also work in the field, and there's been publications on this that, in my view, establish rather firmly that the risk of heart disease is greater with higher levels of smaller LDL than with LDL cholesterol or larger LDL. And that's based on both observational data, that is looking at populations where these can be measured, and we could look at heart disease outcomes, and one can see whether the levels of smaller LDL are more predictive of heart disease outcomes independently of the LDL cholesterol level. And there's a number of large studies that have shown that. They tend to be underappreciated, I'm afraid, by many in the field, including experts that haven't really latched onto that evidence. But in my view, at least from the perspective that I've had over the years, as well as the more recent data, there's no question in my mind that that data exists. So from the standpoint of evaluating risk for heart disease, I would say we've crossed that bridge, in my view, that these smaller LDL do promote a higher risk of heart disease. Then the next clinical question, which is really kind of the payoff question, is can we reduce the risk of heart disease by lowering levels of small LDL? And this is where it gets really dicey, because I've talked about the small LDL as if they're sort of a single entity, but in fact, the small LDL are part of a whole set of interconnected metabolic traits that go along with small LDL. I mentioned earlier increased abdominal fat, increased waist circumference, insulin resistance, and prediabetes are associated with higher levels of small LDL. And that brings into the equation even a broader set of measurements that have been called various things, including the metabolic syndrome, which include not only predisposition to diabetes, but also high blood pressure and and other inflammatory changes, all of which tend to cluster together. So the small LDL level is embedded in this very complex set of factors, which I've called the tangled web of risk factors. And it's very hard to dissociate the small LDL effect statistically from these other variables. That's created part of the issues that have led to controversy in the field about the small LDL as a risk factor. But statistics can sort that out from the standpoint of risk. So I think, as I mentioned a moment ago, one can exclude those other measurements, those other connected traits from the equation when it's talking about small LDL and risk. That small LDL itself is a risk factor. But when it comes to treatment, all of the treatments that we have available to us, starting with lifestyle, diet, exercise, cholesterol lowering drugs that we have available to us, all of them have effects that go beyond effects on small LDL. They can improve small LDL levels, but at the same time that's happening, all of these other interconnected traits go along with it. And so it's been very hard to get smoking gun evidence to say that we can lower small LDL specifically and selectively to reduce heart disease risk. And it's almost an insoluble problem because of the way we're constructed. We're not just consisting of single sets of measurements here and there. We're the product of this whole interconnected set of variables, and we can't change small LDL as yet with any specific treatment that doesn't have an effect on these other measurements. So when it's so inclined, one can disregard the possibility lowering small LDL is beneficial because we frankly don't have the absolute definitive evidence that focusing on that specifically is going to be protective. And that's where it opens the door to people that choose to ignore the small LDL, because one could say, well, if one doesn't have a specific treatment for that, what does it matter? We just use all the standard treatments and we get everything down, and whether it's small or large, we just lower the whole network of risk factors, including metabolic syndrome, including all these other risk factors, along with a small LDL, would be considered sufficient. Now, that becomes an issue that really requires some judgment in trying to extrapolate from what we know about the science to what we can expect to occur at the clinical arena. And as a clinician, I not only do research, which is my main job academically, but I do maintain a lipid clinic, which I've done for many decades, actually. And so from a clinical perspective, I'm exposed to many, many hundreds of patients that I've managed over the years in whom we've done measurements of the various LDL fractions. And there is no doubt in my mind that the treatments that we have to offer, ranging from lifestyle to drugs, when they lower the small LDL sufficiently, can really reduce the risk of events. And I'm sort of happy to say that in my practice, I have maybe a handful of people that have gone on to develop a heart attack or stroke in whom the small LDL levels were low. And part of the issue in that whole equation is genetics. We do have evidence that the tendency to have smaller LDL particles has a genetic underpinning. So we're sort of burdened with the inheritance that we can't control of traits that lead to small LDL elevations. And that creates an obstacle in some cases for being able to effectively lower small LDL levels, despite what we know about effects of weight loss, exercise, diet. We can talk about diet if you wish later. Dietary carbohydrates are a big factor in terms of affecting the small LDL levels. We can do all those things, but some people are just unfortunately burdened with this genetic trait, and we can't necessarily unload them of it. Now, not all those people go on to develop heart disease by any means. So getting back to the initial discussion of heart disease, we know that there's many forms that heart disease can take, and there's many factors that enter into it. I mentioned some of them. And so we are left with doing what we can to work around the genetics, but we don't always succeed, and that is one of the barriers that we'd like to overcome by trying to understand more clearly, is there a specific way we can target small LDL and overcome those genetic risk factors?
Thanks. That was really comprehensive, and hopefully we're going to have time to touch on several of those aspects in a bit more detail. I just wanted to clarify with regards to the large LDL as well. So with regards to the small, I haven't heard anyone question that the small LDLs are problematic and if they're elevated. That seems more or less consensual. So I just wanted to clarify if, with regards to the larger LDLs, if your position is that they are harmless or also bad, but just not as bad as the small dens, what's exactly the your position? Yeah.
It's closer to the second option that you discussed. That is, all LDL particles, as well as there's other particles in the blood that carry cholesterol besides LDL, but in the case of LDL as a particular focus, we know that anything that raises levels of any of the LDL particles can wind up delivering more cholesterol to the artery. So the large LDL, some people have interpreted the work that I've done to suggest that, and the work I described, that large LDL are benign. That's not true, because it's a matter of the degree of elevation. That is, if you get a high enough level of larger LDL, that can be problematic because that can wind up delivering, remember I said it has more cholesterol in these particles. So you're certainly in a position to have too much cholesterol coming into the artery if the large LDL levels are very high. But the properties of those LDL, as I mentioned earlier, are less toxic than the small LDL. So in order to get, in my view, and from the literature, a equivalent risk of larger versus smaller LDL, one would require much higher levels of larger LDL in the blood, and there are people that have that. In fact, one of the important mechanisms that I'd like to touch on related to heart disease risk is not just getting the cholesterol from the particle into the artery wall, but it's the amount of time that the particles are circulating in the blood that can be an important factor. In fact, it may be one of the most important factors, because normally lipoprotein particles, LDL in particular, are cleared out of the bloodstream by binding to receptors in liver tissue, which scoop the LDL out of the blood and lower the levels in plasma. And the liver then takes care of breaking the cholesterol down. And that's the healthy mechanism, which we like to think is operative in most cases. But that can break down. That clearance mechanism can be compromised. And one of the classical ways that happens is through a genetic trait that is extremely well characterized, an important one, that led actually to the award of a Nobel Prize for its discovery. And that is a mutation that prevents the receptor from binding and scooping up the LDL out of the bloodstream. And that leads to a condition which is called familial hypercholesterolemia. And in that case, it's not so much the type of LDL particle, but it's the failure of the liver to remove any of the LDL particles effectively that leads to a prolonged exposure in the bloodstream to the artery wall. So the more of these particles are wandering through the bloodstream looking for a home, a greater percentage of them will eventually wind up hitting the artery wall. And so it turns out that people that have these receptor mutations, that is the familial hypercholesterolemia condition, have a very prolonged circulation time. And in fact, their LDL tends to be larger because it just accumulates more and more cholesterol. And so that's a case where there's undeniably a bad outcome if you have high levels of large LDL. But that is usually associated with an extreme elevation of the standard LDL cholesterol measurement. So for example, if someone with garden variety heart disease has an LDL cholesterol of let's say 130 or 140 or 150 milligrams per deciliter, or the equivalent in terms of metric units, um, uh, that would be considered moderately elevated. Well, when there's this defect in clearance in familial hypercholesterolemia, the levels can go up to 3 or 4 or 500, and that's where we start to see the problem. So it's a relative magnitude of the damage that can be attributed to larger versus smaller that is really important. And it's not a binary, it's not either or, it's both. It's just relative amounts of the two that make the difference.
Got it. Very clear. Yeah. So I like that you clarified that, because I have heard people kind of stretch this in every possible direction. But that was incredibly clear, that both can be potentially problematic, atherogenic, but your view is that there's maybe a different threshold, or or that the curve would be skewed slightly depending on the particle size.
Let me just say one thing. From a population standpoint, I think it's useful to think about the relative contributions of the various conditions that affect the LDL metabolism, because individuals who have this familial hypercholesterolemia syndrome and high levels of total LDL maybe account for 5% of the cases of heart disease in the population. I'm just throwing out a number. I can't give you an exact number, but it's in that range. Whereas the trait in which the small LDL are embedded, which involves this larger spectrum of metabolic syndrome abnormalities, that's the most common trait in the population associated with heart disease risk. It's probably 30 to 40% of the patients with heart disease risk, at least, who have this small LDL related syndrome. And so it's far more prevalent, far more important from a population standpoint than isolated levels of LDL associated with receptor problems that I mentioned. And it'd be important to understand the reason for that, but probably one of the major factors is the fact that as a population, we're all engaged in an epidemic of weight gain that we're now trying to do something about with some new medications. But over the years, we've seen a steady increase in body weight and fat around the middle that has led to the exposure of the genetic underpinnings, the genetic susceptibility to the small LDL syndrome, which is very common. The genetic susceptibility is what creates the framework upon which things like adiposity, excess body weight, and other risk factors add. And as we get heavier as a population, more and more of us are susceptible to this amplification of the syndrome, the small LDL. And it's probably much more common now. We don't have figures from decades ago, but I think in comparison with earlier times when our population wasn't as heavy, I think the prevalence of that trait would be less, and there'd be much less of a contribution to heart disease. But now it's far and away the most important trait, and focusing on the LDL aspect is an important part of it. It's not the only thing you should be worried about, but it is an important component of that increased risk that we're seeing in the population associated with this syndrome.
Mm-hmm. Yeah, I think that's also, as far as I know, very well accepted. I would say almost universally that excess adiposity, visceral adiposity, metabolic syndrome, diabetes, these are all major risk factors, or at least exaggerators of heart disease, of fuel to the fire.
Yeah, exactly. Yeah. No, I'm trying to sort of navigate between what's generally accepted and what's less well accepted and more controversial. So I like to emphasize the things that are well accepted. It's easier to talk about.
Yeah. No, that's a good distinction to make, and I'm hoping to also arguments that I've heard that sort of disagree with the view that there's a major difference in atherogenicity. I'm hoping to run some by you, because some of the arguments I have heard responses to, but some of the arguments I haven't really heard explicit responses to. So I'm really curious to hear what your views are on some of these. One thing that I recently found, and this is the mechanistic aspects that you mentioned. So the smaller particles get into the artery wall more easily, they oxidize more, all of these mechanistic aspects. I was rereading this older piece by Frank Sachs that talks about particle size. And in there, he says something very interesting that this difference in penetrability into the wall by smaller particles is seen in rabbit data, but then there's in vivo human data where that's not seen, and they seem to get into the artery wall about equally. I don't know if you've seen this, and how much truth is there to that?
Well, I think it's actually a small point because uh, when I mentioned that element of the pathology, that is the greater entry, um, it is relatively weak data. I think among all of the properties that I mentioned, I think it's the greater binding to the artery wall of small LDL, it's the greater oxidation that really are the major considerations. There is really weak evidence, and you can point pro or con, rabbits versus humans, that the entry into the artery wall may not be the most important component, but whether it's increased or not. It just happens to be one of the things that's easy to conceptualize, but I would agree with Sachs on this point that it's not something we can point to as being a hard and fast property. Whereas the others that I mentioned, I think are much more well established, at least, and these are all based on laboratory findings. We can't be measuring oxidation in the artery wall in the human body in vivo without digging in and taking out the artery, right? So we have to do these mechanistic properties. We have to study them in a rather artificial setting. So one can argue as well, what is that really relevant to the human body? But I think the evidence for the oxidation step, as well as the binding step, that is the trapping of the LDL, these smaller particles being greater than the larger LDL. I think that is reasonably well established. So one can nitpick about the whether it's more or less entry into the artery wall. I wouldn't consider that to be the make or break aspect of the mechanism.
Makes sense. Another argument that I've seen actually in different publications by different authors is that there may indeed be this mechanistic difference, but then the cargo, the amount of cholesterol that they deposit, kind of levels the playing field. And so even though the smaller particles get in there easily and oxidize more, but then they deliver a smaller amount of cholesterol to the plaque, and the larger particles may get in a little bit less and oxidize less, but then when they do, they deliver more cholesterol, and it ends up being kind of a wash. I've heard Brian Ferentz and I think Snyderman write
Oh,
about
yeah,
different pieces.
yeah.
What's your view on all that?
Oh, I've had a history of debating this with my good friend Alan Snyderman, and I've had some meetings with Brian Ferentz as well, and so I understand where they're coming from. I've written on this. It's just one review from several years ago in the journal that probably people haven't just aren't reading, in which I've tried to dismantle that whole idea for the following reason. Um, the argument being made is that all LDL particles are equally atherogenic, whether they're large or small, and it's the total amount of the particle. So what you said as the hypothesis to explain that is what they are saying. That is, well, the larger LDL have more cholesterol, so it just happens that that exactly balances off the risk. You just can't say that. You can sort of wave your hands and say, well, it should kind of contribute to risk, but to say that the uh, toxic properties or the atherogenic properties, I would say, of larger LDL are the same as smaller LDL, and that exactly balances out. Wouldn't that be remarkable if nature just worked it out so that it was an exact counter effect of larger, more cholesterol? You just can't make that argument. There's no mathematical or analytic data to say that that equation balances out the effects of those two particles. It just that data just doesn't exist. And to say that the cholesterol content matters when those particles aren't getting oxidized and they're not getting stuck in the artery wall, these larger LDL particles, just because they have more cholesterol, it doesn't mean they're going to have these downstream effects once they enter the artery wall, because they don't have, we've shown, and others have shown, larger LDL are relatively resistant to oxidation. They don't have the components that are responsible for trapping in the artery wall. So those particles are fundamentally different from smaller LDL in terms of the properties that we would be attributing to the development of heart disease. And so to say that they exactly balance each other out is just based on no data whatsoever. What is true, and this is where Snyderman and I agree with many others, is that if you measure the total number of LDL particles, or that includes some other particles as well beyond LDL, but that total burden of cholesterol-containing particles in the blood is an important marker for an important contributor to heart disease risk, and that can be measured either by a specific particle count, which tests are available, but much more simply and more widely available through a measurement called apoprotein B, or ApoB, which is a protein that characterizes the structural features as well as some of the metabolic features of LDL and related lipoproteins. And if one measures ApoB as a measure of the total number of these particles, one gets a pretty strong and important relationship to heart disease risk. So that's an important step away from relying on LDL cholesterol, which does not always match the ApoB level. You can have discrepancies where ApoB is high and LDL cholesterol is low. Those are situations, by the way, where there are smaller particles, more particles for any level of LDL cholesterol. But the ApoB measurement is a surrogate that serves quite well as a risk marker. And so I have no argument with that. I think ApoB is an important measurement, but it doesn't discriminate among the various types of LDL in the blood, so that you can have a high ApoB level. And this gets back to the arguments that Snyderman and others make. At a high ApoB level, does that mean that you just happen to have more cholesterol-containing particles and larger particles and smaller particles, but you have a total increase in the number? Is that ApoB sufficient to tell you what is responsible for that increase? Is it small or large? That's where it gets down to fine-tuning risk assessment and targeting more specifically what I feel, and that many of my colleagues I think feel, but a minority still, that if you can identify the type of particle in the blood, smaller or larger, LDL in particular, that one then can get a finer assessment, a more meaningful assessment of what's responsible for that ApoB elevation. Otherwise, we don't know where that ApoB is coming from large or small. It's a good surrogate overall, but it's not a perfect surrogate. And furthermore, it doesn't tell you what one might be telling individuals they should be focusing on in terms of treatment targets. Should we be worried about the small LDL because the conditions that promote increased levels of small LDL, excess adiposity, and carbohydrate intake, we can talk about if you wish, are not the same as effect levels of large LDL. So if one knows where that ApoB is coming from, one can decide where one should direct one's therapeutic energy. Should we be working on things that affect small LDL or not? So that level of measurement to me is a logical next step. And the only barrier, well, there's several barriers to taking that step, one of which is accepting that the type of LDL particle is important. The other is the general limited availability of testing for larger, smaller LDL. So that kind of limits the power of diving more deeply into the forms of LDL in the blood. But if one were to have access to the right methodology, and if one were to use it intelligently, one would say, well, you as an individual need to focus on things that will lower your small LDL because you have that condition. And the ApoB level is not sufficient to tell you whether it's small or large LDL.
Mhm. That makes sense. Along the same lines of this controversy, is ApoB sufficient or not, or or does the measurement of the particle distribution, the particle size, um, yeah, which one is the big dog? Another argument that I've seen many times, and some of my guests have brought this up as well. So this is one of the reasons I wanted to have you on and hear uh, this view as well. So I can I can have all of this in my head and try to as I try to figure this out, and also expose my viewers to all these different ideas that are all um, based on scientific evidence. So the idea that this depends on these adjustment models, because as you explained, people who have a lot of these small dense LDLs tend to also have more diabetes, more metabolic syndrome, sometimes higher blood pressure, and they correlate well with the ApoB as well. So people who have smaller particles tend to have more particles overall. And so it all is going to hinge on these adjustment models. Can we parse out all these confounders to isolate the effect of the small LDLs? And so one thing that I've seen over and over is um, that most of the studies that find an independent effect of small dense LDLs in risk don't adjust for ApoB. Not all. I think I've seen a couple of exceptions, and vice versa. That most of the studies that adjust for ApoB um, render the effect of small dense LDLs non-significant. Actually, one just came out last month, or it might have been even this
Yes,
a large.
I saw that.
But
Yeah, I saw that. That unfortunately they used the paper I think you're referring to. Was in Circuit. It was in one of the American Heart Journals, I think. They use this is a real sore point for me
mm,
because there is a measurement that has become widely available around the world using a procedure called NMR, nuclear magnetic resonance spectroscopy, that has been promoted and been made available by a company. I'm going to name the company because I really wanted to point my finger at them. It's called Nightingale. It's based in Europe, and they have saturated the literature with basically a junk assay. Um, we published on this to show that their analysis for the LDL particle concentrations, in particularly smaller and large and medium particles, is deeply flawed and fails to uh, identify really in a meaningful and accurate way the smaller LDL particle component. And that paper, if it's the same one that you're thinking of, unfortunately base their conclusions on using that assay. So the entire conclusion, and this is something, this was fairly recent, and I haven't decided whether or how to deal with this because I've given up trying to expose this in the literature. I think it's just not uh, making much of a dent compared with the saturation approach that the company has taken in terms of offering this test. People just love it because it measures 100 different things and it measures all the particles at the same time. It's just not a meaningful test for LDL, and therefore I think the conclusions of that paper are flawed. Now, you mentioned the adjustment issue, and I touched on that earlier, the statistical interweaving of all these tangled measurements that are all related to one another. It is, as I mentioned, challenging to tease them out. There's no perfect way of doing that. You're right about one thing, and that is uh, that most of the studies have not uh, tried to adjust the small LDL heart disease association for ApoB. There's just, in fact, I'm not even aware of a good paper that has done that. What has been done repeatedly, and this is something I touched on earlier, you can adjust for LDL cholesterol, that the standard LDL measurement. When you adjust the relationship of small LDL to heart disease for the standard LDL cholesterol, by and large, the great majority, in fact, I would say at least the great majority of studies show a residual significant risk of small LDL that is independent of LDL cholesterol. Now, in the case of ApoB, it is correct to presume that because of the strong relationship of ApoB to small LDL, if you adjust for the ApoB, you're going to diminish the relationship with small LDL. That doesn't mean that the small LDL aren't causative. It just means that you've got such a tight connection of those statistical measurements, those measurements statistically, that you can't. And ApoB, by the way, from a measurement standpoint, is actually, how should I say, more readily standardized. So ApoB becomes a pretty powerful tool, not just because of its relationship to heart disease risk and the number of particles that are responsible for that risk, but also because its measurement is very tightly standardized. And so the more reliable the test is, the more likely it is going to show up as being predominant factor. So if you adjust for ApoB, a really tight measurement for the LDL particle relationship, ApoB might win out, but not because we're measuring the same thing or because it provides equal information. It's partly related to the characteristics of the measurement itself. And again, I would back up to what I said a moment ago, and that is, I'm a big fan of ApoB. I have absolutely no concerns about ApoB being a powerful and useful risk factor compared with the standard lipid measurements. But it doesn't mean this. It doesn't mean that relationship is sufficient to pinpoint what's responsible for that. That's what I said that a moment. I'm repeating myself. It's really a matter of knowing what's responsible for it that matters when it's dealing as a clinician. What are we going to do for the heart disease risk in this patient? How do we know by just measuring ApoB? Well, you can lower ApoB very powerfully, and if you lower it enough, it probably is sufficient to wipe out the risks associated with small LDL because you just have less particles. What really matters, it's not quote the size. People have often misunderstood some of my earlier work saying that LDL size is what matters. No, it's not LDL size. It's the amount of LDL of a certain size. It's not just whether LDL on the average is larger or smaller. It's how much of that small LDL is in the circulation. And that is really what we should be thinking about mechanistically and clinically as the target for effective intervention, is getting this number of those particles down. And if you blast somebody with all of the powerful lipid-lowering drugs we have available, statins and other drugs such as PCSK9 inhibitors are a big thing now as well. You can get the LDL levels down, the ApoB levels down so low that the number of small particles is also very low. So you can achieve a therapeutic reduction in small LDL if you just knock the stuffing out of the total number of particles. The challenge there, and this relates in part to the genetic situation I mentioned earlier, there are many people, certainly those that I see in my clinic referral, who can't get the LDL that low. When it's trying to use these powerhouse drugs to knock the stuffing out of your ApoB level or your LDL cholesterol level, you just may not be able to get down to the levels that would result in lower concentrations of smaller LDL. And so those people are still sitting around with an excess of risk because we haven't been able to get the LDL low enough.
Gotcha. Yeah, that's an interesting point that you made about the techniques. I don't think I've ever heard that before. That if you adjust for ApoB and the effect of the small dense LDL goes away, at face value, the interpretation would be okay. So it's all about the number and not about the size. But you're pointing out that it could just be characteristics of the assay itself could confound that analysis. So as you're explaining that, I was thinking, what if the adjustment uses LDLP instead? Because that's derived from NMR, right? So that would be more apples to apples?
That's been done too. And there has been controversy. And people love to quote papers in literature that I feel I'd like to think I've challenged. I'm not sure I've challenged them successfully because it hasn't been understood. But that adjustment is complicated. And it's too much getting into the weeds to explain why. But the general idea is that there's not a linear relationship of ApoB or total LDL particles to LDL size. It's a curvilinear relationship, and when you try to adjust statistically something that's nonlinear, sorry to get too technical here, but you're not using the statistics appropriately. And I've actually had a rather extensive rebuttal to the argument that adjusting for total LDLP eliminates the effect of LDL size or small LDL concentration. It just falls apart when you do the statistics the right way. And the statistics have not been done the right way in the literature. So it's unfortunately confused the literature, and people who like to downplay the significance of small LDL like to point to the articles that say, well, it doesn't matter if you measure total LDLP. Now, having said that, I'm also an advocate for total LDLP measurements for the same reason I'm an advocate for ApoB. There's nothing wrong with total LDLP. I use it in my own clinical practice in conjunction with the subfractions, the smaller, larger fractions. But it is, and so it's very much in the same ballpark as ApoB. It's giving very closely related information. And so if one were to measure LDLP accurately, and that is an important word, accurately, one has advanced a big step towards refining heart disease risk, but it doesn't go all the way to saying, if you measure total ApoB, are you measuring mostly the large or small? And so I'm perfectly in favor of moving to either of those measurements, ApoB or LDLP, as a pretty powerful step towards getting the right answer. But it doesn't take you all the way to mechanism.
Mm-hmm. Yeah, so there seems to be a number of issues, both at the level of the tests themselves and then the statistical analysis that are a little uncertain. There's some uncertainty around it. As you said, there's different ways to do the statistics that haven't been tried. So that would be interesting to see if doing it that way that you're suggesting would change the results fundamentally, looking at some of these data sets and applying that.
Well, I actually used, I've taken some data that I've had available to me to show that. Now, I can't dig into other people's data at this point, but it would be interesting to do that.
Yeah. So moving to the other lines of evidence that maybe get us a little beyond this, because everything so far is from these purely observational kind of epidemiological findings that have all these confounders. I don't know, maybe the other lines of evidence will also be equally confounded, but we'll go over them just to see if there's any clarity that can come from there. So genetics are another line of evidence, and you've touched on that already. Here I've seen sort of a similar message, but maybe prone to some of the same confounders. But a few of these Mendelian randomization studies that I've seen, the claim is pretty similar, that when they adjust for the number of particles, they don't see much of an effect of particle size, of the small particles being nastier than the large in some of these studies. But are the same issues also applicable here?
Well, the Mendelian randomization studies, as far as I know, they look at LDL size, but don't have access to the LDL particle concentrations, at least the ones I've seen. Now, there may be things I've missed, but as I mentioned, LDL size as a measurement is really just a single index of the relative amounts of large and smaller LDL. It doesn't tell you the absolute amounts. And the Mendelian randomization studies that I've seen have not really dived into the actual, at least other than this Nightingale method I mentioned, which is flawed. I haven't seen this done for LDL particle concentrations. I may have missed something.
There's one from Dan Rothers. I don't know if it's Rother or Rader that his name is pronounced, but Rader. So he looks a lot of HDL particles, but he also looks at the different classes of LDLs. And I believe there was an adjustment for particle number. Now I forget if it's ApoB or LDLP that he uses, and I definitely don't remember if it's the Nightingale company or not. But those are all things that would be interesting to clarify.
Probably not.
Okay, yeah, and that study, actually, that study they concluded that there is weak evidence. Actually, they found a slightly stronger effect for the large LDL, but they say that it's very weak evidence. So they're not making a strong claim. But if anything, they see it tilts towards the large LDL being a bit more associated with a slightly higher risk in that study. Um, so yeah, with the genetics.
Oh, listen, yeah, I just tell you, I published a paper that Frank Sachs in particular loves to quote because years ago we studied a population that was selected for individuals who had normal lipid levels but evidence for coronary blockage from angiography.
Mhm.
And we showed that in that population, larger LDL size was associated with higher risk. So there's no question you can find situations where that occurs. As I mentioned, it's not a binary issue, and it may be very dependent not just on the statistics, which I can't comment on because I don't know the details of the study you're quoting statistically, but I can say from a standpoint of selecting populations to study, one can get different results.
Mhm.
And as I say, there are people who are at high risk for heart disease who have a large LDL. There's no question about that. There's no debate about that. It's just a question as to you learn something more um, about the underlying trait itself, uh, not even whether it's associated with more or less heart disease, but when it is associated with heart disease risk, what do you do for it?
Right.
Rather than comparing it, between small and large and all that stuff, which you get lost in the statistical noise very easily, is to say, well, does it matter for how we approach that patient? And this is where I put my doctor's hat on. I say, I think it does matter because the ways we treat those conditions are different.
Mhm.
And we'd like to know what it is for treating. Um, uh, but there's certainly situations where large LDL are. I wouldn't even argue against that. It's just that one has to look at the collective literature. And Mendelian randomization, by the way, isn't all. I won't get into this either, but it's not all it's cracked up to be. It's not a perfect tool because with Mendelian randomization, you're dealing with genetic markers that have multiple effects. It's very hard to pinpoint a genetic marker that just affects one thing. That's the way you're supposed to do it, and then adjust for all the other things that that gene might be related to. Well, that involves some statistical. I've been involved with a recent study on another topic altogether, in which we've just taken apart the Mendelian randomization issue when it comes to complex traits. It's much too hard to separate genetic effects that are only focusing on one axis without affecting something else. So there is it sounds razzle dazzle and it has mechanistic interest to some extent, but it's not the be all and the end all in terms of deciding if this is the way you should consider a statistical adjustment for something that itself is really complex and has interwoven features that can be hard to tease apart. I don't want to sound nihilistic about it, but I just don't feel there is as yet a really uh, robust analytic approach using statistics in particular that can really successfully tease apart all these interrelated factors. And one can, um, I've worked a lot with statisticians, and one of them who has a good sense of humor says, "Well, I'll help you with this project. You just tell me what you want to show.
Right.
What is it you want to prove it, and we'll do the statistics to make it happen."
Yeah. No, I agree that the Mendelian randomization has lots of limitations as well. I mean, I think every line of evidence has limitations. Um, and at the end of the day, it's by putting all these things together that we kind of get a glimpse of what might be true. But I like what you said that there might be maybe the difference in populations. Maybe that helps explain these different observations. Maybe the small LDLs play a more important role in some specific populations and not others, and maybe that explains this heterogeneity.
Well, that's definitely true. There's certainly no question about that. The small LDL is really probably most meaningful, other than the people that are genetically hardwired to make small LDL. The bulk of the people that carry this trait um, really can be identified as those that fit into this metabolic syndrome category. That's really, I think, where the impact of that. And as we talked about earlier, I think there is a consensus that the metabolic syndrome includes the small LDL in the vast majority of patients who have the metabolic syndrome. And therefore, it's part of the whole, what we say, atherogenic mix. That's where I think there's consensus, right? And so once you accept that, then you say, well, I'd like to know whether my patient has this abnormality, and is there anything we would do differently if we knew that? And often that's not the case, because if somebody needs to lose weight, that may be sufficient to eradicate the entire profile if they can lose enough weight. So it's not always necessary to know. I don't measure small LDL in all my patients, I can assure you, because there's lots of information we get on the clinical circumstances, their population we're dealing with, their other risk factors, that and how low their LDL levels might get on treatment, that make it less necessary for us to get into the details of whether it's smaller or larger LDL. But there are a large number of people that have this underlying small LDL trait that is buried, that is not revealed by LDL cholesterol. It may be strongly suggested by an ApoB level, an LDL particle level, but as I said probably several times too many by now, it doesn't tell you what the actual abnormality is.
Right. Another line of evidence, maybe this one will be more conclusive, or maybe not. Maybe we'll also have plenty of these confounders. But yeah, the randomized trials. So I know the story with statins and particle size has been discussed a lot, and in general, I think it's well accepted that statins lower mainly the large LDLs, although they might also have an effect on the small LDLs.
Yeah, it's a relative effect. We have a couple of papers showing that there's yet another category. I've talked to you about LDL particles as if they're just larger and smaller. Well, there's actually 7 different types of LDL. We don't get into all of that usually in the clinic, but there is one subtype that is sticking out at the small end, which we've termed very small LDL. These are tiny LDL that are the extreme of small LDL, but they're a separate species. They have different genetic effects and different determinants that are also associated with heart disease risk. Those don't budge with statins. There's absolutely no effect of statins. We've shown that in a couple of different studies. The other particles, which are more abundant, the classical small LDL and the larger LDL, are all responsive to statins. The larger LDL tend to respond better. So it's a relative difference in the capacities. But you can get the small LDL particles low if you give sufficient statins in a high proportion of patients. Just may need more statins, or you may need adjunctive therapy to achieve that.
Do the LPA particles, LP(a), would that be included, or is that separate from these classifications?
Yeah, that's a good question. I was wondering when and how you wanted to get into that, because LPA is another risk factor for heart disease that 40 years ago I would have said was emerging as a risk factor, but it's taken the full 40 plus years for it to fully emerge and get the attention of the medical community as well as the pharmaceutical industry. And your question is, where does that fit into the picture here? Well, just for your viewers, to review, LP(a) is a particle that looks a lot like an LDL particle. In fact, it is an LDL particle to which a specific protein is attached called apo(a) in parentheses, that carries with it an extra burden of pathology. It promotes even greater oxidation than smaller LDL. It promotes thrombosis, inflammation. It's a bad guy. And it's been strongly associated with heart disease. It's, however, strongly genetically determined, very difficult to move. And there are now treatments coming along that may get us over that hump. But the LPA particle concentration is buried within the LDL. It's part of the LDL. So when we measure total LDLP, for example, you're measuring LP(a) along with it. So that's another example of not distinguishing within a total LDL-P measurement is part of that Lp(a), is that because that would really affect one's likelihood of success if one can't lower that with medication. One would like to know in advance if that's what's responsible for the high LDL-P. And unfortunately, the methods that are out there for LDL particle assessment, all of them, including the one that I'm responsible for, as well as that NMR method I mentioned earlier, don't tease apart the Lp(a) component of the LDL-P, the LPA component of the LDL-P measurement, and so one has to measure that separately, and that's done typically by immunoassay. So it's a bit of mix and match. We can't really define LPA particle concentration easily without measuring without using the immunoassay.
Mm-hmm.
So it has to.
Yeah. So doesn't that mean that all the results we've talked about so far with small dense LDLs would be also involving LPA, or is that not included there?
So that gets into a really interesting question, which you better stop me if I go on too long about this, because I think it's extremely interesting. This protein ApoA binds to LDL particles, but it can bind to different kinds of LDL. It can bind to any kind of LDL. We assume it's not just smaller or larger. So when we measure, and the important thing about it is it's not small; it's large. That binding actually moves it from a smaller size, whatever the size is to start with, small, medium, or large. It moves it to a larger size because it's adding on a large protein on the surface. So when it measures small LDL, when it's not measuring Lp(a), it's not there. It's in a different size range altogether. If anything, it's part of the large LDL equation. So one can argue, and I just thought of this in relationship to an earlier question, when one points to evidence that larger LDL could be associated with higher risk in certain situations, that could be the Lp(a) because it's a larger particle, and it contributes to the large LDL-P particle measurement. So it's on the other end of the spectrum. However, the interesting part, which I'll only talk for a minute on, is that when there is really, how should I say, not this well-established evidence that when the ApoA, that protein, is bound to a small LDL particle, it can multiply the risk of the LPA level. So it's not just the ApoA protein that confers the risk; it's the LDL type of LDL onto which that protein is bound. So if you have both the protein genetically determined sticking to the second component, the small LDL, that's what I would call the dynamite. That's the explosive combination. And there is some evidence, and some of it's unpublished from my own experience, that can multiply the risk for heart disease if you just measure the LDL-P level. So it's an interesting mechanistic question as to the combinatorial effects of the ApoA protein and the various properties of the LDL to which it's bound.
So in the measurement, in the NMR measurement, when they measure the diameter of the protein in nanometers, that can include that weight scale? Okay.
I've had discussions with the person that's responsible for the main NMR method. It's in Houston, the U.S., Jim Maffos, and we certainly, we both recognize, he recognizes that you don't get the LPA measurement out of the NMR spectrum. You just can't get it. You can make an intelligent guess, but you can't really measure it. And the same is true for a measurement that I favor, which measures LDL particles directly. That method also does not discriminate the LPA from the LDL particles. So there are people, and I've seen this in my clinic, and certainly I think it's been in the literature as well. There are people in whom the majority of the cholesterol carried in the LDL in the blood is actually coming from Lp(a). That the true LDL particles, the ones that don't have the protein on them, may be very low, but the LDL cholesterol level and the LDL-P level looks high because most of the particles are Lp(a), and that's an important reason. I mean, I've been a huge advocate ever since my training days for including LPA measurements routinely, because you just can't get that information any other way other than by this immunoassay method. And finally, now that the drug companies are paying attention to this as a target, we're seeing people pay more attention to discriminating that, because you need to know what you're treating. In fact, it's not terribly different from the argument I mentioned earlier about small LDL. If you have high Lp(a) contributing to the ApoB level, or you want to know that, right?
Yeah.
You want to know that. So we're going to make almost the same argument for small LDL. It's not, a small LDL isn't quite as as toxic as Lp(a), but it's the same argument. You want to know what it is that's responsible for the high LDL-P. Just so it's a very parallel argument, actually.
Yeah, that's very interesting. I didn't know that. I didn't realize that the LPA. Yeah, it sounds like it's clearly something that could confound these particle measurements and these fractions, and something that's going to have to be out in the future. Otherwise, it's going to be hard to figure out this effect of.
Yeah. We tried. We spent more time than I care to admit trying to tease our method, our particle size laboratory measurement, to be able to tease out the LPA component, and it just can't be done.
Yeah. I had two more kind of questions along these different lines of evidence. Another one is looking at similar questions. So looking at populations that have high LDL cholesterol, but don't have these other issues. So they're lean and they're insulin sensitive. They don't have diabetes. There's a number of studies that have tried to do this, looking at whether the LDL cholesterol is an independent risk factor. So there's a couple from the Framingham cohorts. There's another one from Spain that tried to do a similar thing. In general, with all of these, they still show that with higher LDL cholesterol, they still see more plaque or plaque progression or higher risk than people who have lower LDL cholesterol, even in the absence of metabolic syndrome, diabetes, insulin resistance. So I was wondering if this is a test of the heterogeneity of the large particles, because these populations we would expect to have, if they have higher LDL cholesterol and higher ApoB, presumably it'd be mainly at the expense of large LDLs, right?
Right. So this gets back to not a static measurement, but considering things more dynamically, and it relates to my comments earlier about circulation time. Those individuals who have higher levels of larger LDL and higher heart disease risk, and I'm just going to throw this out in general, are much more likely to have that high LDL as a result of failure to clear, because hepatic clearance of LDL is the major mechanism for regulating blood LDL levels. So if you start off with a set of individuals who have high LDL, who are otherwise lean, healthy, and who are shown to have risk for heart disease, I would just throw this out as indicating a pretty great likelihood that their high LDL is due to impaired receptor clearance. And this, because what's been shown is there's a zillion variants of the LDL receptor gene, among others, that can vary across the population, that can affect the efficacy of clearance of LDL. So these people may be burdened with one or more of these genetic traits. Their LDL isn't being cleared properly. They have higher levels. That doesn't mean that the LDL are more or less atherogenic. What it means is that the LDL are atherogenic, but they're circulating around for a longer period of time because there's an impairment of receptor-mediated uptake. That is, it's not speaking to the inherent properties of the LDL particle as much as it is for their metabolic behavior. That is, they're not being cleared, and that's why the LDL level is high, and that's what leads to higher heart disease risk, because those LDL, rather than going to the liver and getting broken down and cleared, are being bound to the artery wall. So it's a mistake, and I'm not being critical of you. I'm just saying it's a mistake to extrapolate from the LDL particle characteristics to what we see going on in vivo, because in vivo it's a dynamic situation. It's really, in my view, the most probably, I would say, in the context of an informal discussion like this, I think the most important factor dictating risk is the circulation time.
Mhm.
Because smaller LDL circulate longer because they're less bound by the LDL receptor. I'm not sure we mentioned that, but they do have enhanced circulation time. That's been shown by kinetic studies. Um, Larger LDL can be cleared more efficiently, but if their levels are elevated, it's likely because the clearance mechanism itself is defective. So it's a completely different mechanism,
Mhm.
and it could result in pointing to large LDL as being, bad for you, but that's not necessarily the explanation. The explanation is much more likely, in my view, to be that they're not being cleared as effectively in those individuals because they have an underlying clearance defect. Is that clear? Because
Yeah, yeah,
it's a
yeah.
little complicated.
Yes, yes. You're saying that the mechanistic explanation is different. It's if they were matched in the blood, if the large and small were at the same amount and the same residence time, then that we would see a difference. But because the large LDLs are staying there longer, then the heterogeneity or the harm is enhanced.
Right. Yeah. I mean, this experiment hasn't been done. It probably can't be done. But as you just suggested, and I think this is a good way to phrase it, if the clearance was identical between the large and small, the residence time was identical, would the small LDL have a greater effect? My prediction would be yes. But fortunately, that experiment can never be done, so it can't be disproved. It can't be disproved.
At a practical level, this still does argue, and let me know if you disagree, that the large LDLs are a concern if, for example, their clearance is defective, which comes into play with a lot of these interventions, right? I mean, both statins, for example, act at the level of the clearance, they increase clearance, and some of the dietary induced elevations also work at the level of clearance. So for a lot of these things, they would affect the residence time of these large particles. And so if they are there for a longer time, they would potentially be problematic.
Right. Yeah. And efforts to improve the clearance would reduce their impact on heart disease.
Yeah.
But again, that relates a bit to the one of the things I mentioned earlier, and I'm going to cycle back because I have done for some other points, is to the prevalence of these traits in the population. The isolated high LDL as a risk factor for coronary disease or in patients who have coronary disease is a relatively small proportion of that population. It's not trivial because there's zillions of people affected, but as a proportion of the total population, it's not great. And it's, so those individuals um, uh, really pale in comparison with the number of individuals who have clearance defects, not because they have an LDL receptor problem, but because they have an LDL particle problem, in my view.
Mhm. Which is kind of an indictment on the health of our population that most people have multiple risk factors. They are not only do they have high number of particles, but they also tend to be overweight and they tend to be a bit pre-diabetic and all. Blood pressure is not great, so it tends to be kind of this perfect storm. Um, and then, yeah, the last thing that I found on this topic of small particles, and then we can maybe move on to foods, which is interesting as well. Um, I found some autopsy data looking at, I think it's electron microscope, and looking at the plaque, and they're trying to count the number of particles in the plaque by nanometer range. It wasn't like clearly just small LDLs that were present. So, for example, the range between 26 and 27 nanometers, which I think is a medium to the larger, no?
The particles in the size, now we're getting down into the really nitty gritty here, but the particle size that you quoted really reflects a whole nother category, something called intermediate density lipoproteins,
Um,
otherwise known as remnant lipoproteins. Remnant particles are very bad. So it's another category. You have the small LDL, which actually derive from remnant particles. That's metabolically a precursor product relationship. But the remnant particles themselves are really bad guys. So we have small LDL, we have Lp(a), we've got remnant particles. They're all different species of lipoprotein. And what's been shown in the artery wall, in the two studies that I've seen, is particles and they would fit the size range you just mentioned, that are probably remnant lipoproteins that got stuck. They're larger than LDL,
Mm. Okay.
and
Yeah.
because I don't know of any studies in particular that have found small LDL themselves in the artery wall. I just am not aware of anything like
Mm.
that. I think it might be very difficult to find them, actually.
I'm looking at their data. They find anywhere from 18 to 19 nanometers. I mean, all the way to
Well,
higher. Uh,
18 to 19 would be very small. Would be very small LDL.
okay.
Well, that's good. That gets into the artery wall, right?
Yeah. And then so the large LDLs would be what size?
21 to 23, something like that. 24.
Oh, okay. And then above 23 would be kind of IDL range.
Yes,
Okay.
in that range. I don't remember the precise numbers, but it's in that general range. But once you get into the 24, 25 range, those are more likely to be IDL and remnant-derived particles.
Well, around the 20, 22, 23, 24, 25, they find plenty of particles in there in the plaque. Yeah.
I mean, there's no question. They can all get in. It's not as if it's a yay or nay. And
Right.
so you can count the number of particles. I've worked with a lot of electron microscopists, and you trust them to do the best job, but they have to select regions to look at in the in their tissue specimen, and you can, it depends what you just where you're looking in part what you're going to see.
Right.
So I'm not surprised that all the particles are present, but you don't know. You also don't know whether the relative amount is really representative of the entire arterial wall.
Mhm.
Um,
Yeah. Just a quick note, guys, before the video continues. After our discussion, we continued to correspond, and Dr. Krauss raised another concern he has about these autopsy data. Basically, the particles could be changed or could be degraded once they're already inside the wall. So that could skew this picture. For example, small LDLs are more oxidative, so they may be degraded more so that their number appears lower than it really was when they got into the wall. Also, the IDLs, which are larger than any LDLs, they could be degraded and get smaller and start to look like large LDLs, even though they were initially not. Bottom line is there's a lot of uncertainty with these images from autopsies, and I agree with that. Question that I've seen people raise with regards to this potential differential role of the small and the large LDL. People have asked, so is it worth trying to increase the LDL size? I have a lot of particles and they're smaller. Should I try to make them larger?
no, I'll give you one word answer. The answer is no.
Okay.
And that's because the size itself, as a single measurement, as I say, that's just the measurement of the average size of all the LDL particles. Going from smaller to large, it's not the LDL size that matters, it's the amount.
Mhm.
So if that shift is a result of lowering levels of small LDL sufficiently, then I would say that's therapeutic. But it's not because it's shifting it to larger LDL. It's just because it's lowering small LDL. In other words, you can affect a change in the mean size by differential reduction of small versus large. If small is going down in LDL and large LDL is remaining the same, the average size is going to go up. But that doesn't mean the LDL particles are getting larger. It just means you're having a selective reduction in the small versus the large, and that shifts the average to a larger size. But that's meaningless biologically. You're not actually changing the size of the particle. You're changing the amounts of the smaller versus the larger LDL differential. And is it good to shift from smaller to larger, lowering smaller LDL and increasing larger LDL? Well, I don't know the answer to that. But the important thing is how much smaller LDL you're reducing.
Because you could reduce the small LDLs and you could at the same time increase the large LDLs. So the ApoB number would stay the same, but you have
Right.
fewer
Yeah.
small
And it's
LDLs.
conceivable, right? And it's conceivable that you could raise this large LDL in that scheme sufficiently high so that you've eradicated the benefit of lowering the small LDL.
Mhm.
So that's another reason I don't focus on LDL size.
Yeah,
I'm just focusing on the relative concentrations of these particles.
got it. Yeah, I think it's a fascinating topic. Obviously, there's lots of different points of uncertainty, but I think it's good for people to also be exposed to this. Yeah, to
Right.
the ideas and to not everything in science is clear cut and completely black and white.
That's for sure. Well, you've certainly shown yourself to be well read in the field, and I hope we've addressed some of the major things that have been puzzling you. I don't know about your audience, but I'm hopeful it's been helpful.
It's stimulating, that's for sure. If we can close with the foods, I think it's an interesting question to close on. I know there's lots of debates on the saturated fat, but one thing I've heard you say in interviews that I completely agree with is that if we focus less on individual nutrients and focus more on actual foods, because that's what people buy, and more dietary patterns, and this is a more actionable level. And to a large extent, when we focus on foods, the nutrient questions tend to take care of themselves. So based on everything we know, what are some healthy foods, particularly for heart health?
I'd have to say that this is an area of controversy as well, because um, in terms of dietary components, um, if one talks about plant-based foods, multiple types of plant-based foods, their overall relationship to heart disease risk is sufficiently favorable that they should be encouraged. I mean, I think there's consensus around that from all quarters that focusing more on plant-based foods, which most people, frankly, don't get enough of in their diet, would be promoting heart health. Within that general broad category, are there some foods that are more beneficial than others? I'm not sure I could really point to studies that I believe. There's a lot of, I've done a lot of work in nutrition research, and I'm aware of all the issues surrounding where the support for those studies come from. And I'm hesitate to bring this up, but a lot of the studies are focused on foods that the sponsors are interested in promoting. And you can say, well, this food is good for you. Pistachios are good for you. Or um, uh, the more I think about it, though, probably the one category of foods that stands out, and because I haven't really thought about it quite this way, I thought about it in more broad dietary terms, but many categories of nuts, I think would be considered heart healthy for different reasons. Walnuts, content of polyphenols, almonds for fiber content and cholesterol, potentially cholesterol effects. Um, Probably most nuts, not all of them have had the research support that those two kinds of nuts have had. But I think the evidence would point to those being beneficial. There are a lot of people that feel that seed oils coming from seeds and nuts are beneficial. Others think they're harmful. I don't want to get into that controversy because I don't feel I understand it well enough to make a meaningful judgment. But it's the foods in which those oils are contained rather than the oils themselves that I think are really, and that gets back to the plant-based diet. So I'm sorry, I can't point, this gets asked a lot actually, what foods should I be eating to reduce my risk of heart disease? And I would say, well, reduce your risk of certain foods that we are concerned about. Processed red meat, for example, for a variety of reasons. Watch out for cream and butter in terms of your LDL cholesterol. But other than that, there's not much else. I just was talking to a patient earlier today about this. There's not much else that is on the list of things to avoid. Even cheese is probably not harmful in terms of cholesterol or heart disease risk as much as people think. But on the plus side, it's much of everything else that can be traced back to a plant-based origin.
Oh, you touched on carbohydrates in the beginning. I just wanted to get your take on kind of whole forms of carbohydrate versus refined. What's your take on that? So let's say whole grains like oats and then refined carbohydrates. How do you view those two?
Okay, so I was educated on this when I had to write a chapter on this earlier on in my career. And I've sort of been left with this model, and that is that any carbohydrate that has its original kernel attached to it, unchopped, is probably going to be okay. It's not helpful for other reasons because of other properties of the food. Once you start cracking that kernel in any way, shape, or form, even if it's whole, so-called whole wheat, that whole wheat can still consist of broken down kernel, which makes that carbohydrate more digestible. And the rate at which that carbohydrate is absorbed when it's lost its shell is one of the things that triggers the series of events, including insulin resistance problems and leading on to diabetes risk, as well as lipid abnormalities. And so it's the degree of, we've been hearing a lot about processed foods these days and ultra processed foods. Well, my argument is unless you are eating really whole kernel carbohydrates, and here I would include, to answer your question, steel cut oats would be an example of something close to that. Dark rye, pumpernickel, where you really have the full rye. You look at the number of grams of fiber per package, and you'll get an idea as to how processed that's been. More fiber, better; less added sugar, better. And then after that, it's really it gets progressively worse as you get more and more processing, and then you start getting into the horrible effects of fructose and sucrose, which of course we would like to limit intake of because that has probably the most profound effects. So it's a spectrum again, but I personally, and things like cereals, people who eat cereals in the morning, there are things, and I won't give brand names, but there are some cereals that are exclusively high fiber with no added sugar. Those are the ones that have the least processing, and those are the ones that I recommend to my patients. Once you start getting into the cereals that look like they're whole wheat, most of them aren't.
Mm-hmm. So that mostly whole and intact, not just whole, but intact grains as opposed
Right.
to levels of processing.
Yeah.
Okay, quick recap of everything we talked about. Dr. Krauss views small LDLs as more harmful than the large LDLs, but large LDLs are not benign. They can be atherogenic if their concentration is very high or if they have a very long residence time in the blood, if they're not removed properly from circulation. People who have a high number of small LDLs, that's much more common in our society. This happens in the context of metabolic issues, metabolic syndrome, obesity, prediabetes, diabetes, whereas people who have a lot of large LDLs, that's less common. Dr. Krauss feels that measuring particle size, distinguishing particle size can be helpful. In some patients, not all, mainly to define the therapeutic approach, what to do next. And finally, foods that Dr. Krauss recommends for heart health include nuts, whole grains as intact as possible, so things like steel-cut oats and dark rye bread. And on the other hand, foods that he finds more concerning include processed meats, so bacon, beef jerky, deli meats, butter, cream, and also processed grains. The more processed, the worse. And also added sugars, so table sugar, soda, or highly refined cereals like you're likely to find in the cereal aisle, like Fruit Loops or Cocoa Puffs.